When we begin to think about metastatic castrate-resistant disease, there are a series of pivotal trials. And these pivotal trials are all published either in the New England Journal or, in one case, Lancet. And they've been conducted really since 2004. And this is a really quick summary. There are a couple of things that I think you need to take home from this slide. Number one is that we used to look at castrate-resistant prostate cancer in the context of progression after ADT. And that's really no longer the case, because exactly what William was saying is absolutely true. All of these newer agents are moving earlier and earlier. And when docetaxel came out, we then created the post-docetaxel space, and that space got filled up with things like the TROPIC trial with cabazitaxel, initially Cougar 301, which was the first abiraterone phase 3, and then Affirm, which was the first enzalutamide phase 3. And then Alcimco, which was an innovative trial with radium, showed that whether or not docetaxel was used or not in a stratified analysis, that radium could benefit, but there were no novel hormones at that point. And then the Profound trial, which is, of course, the first PARP inhibitor trial to show an overall survival benefit, was positive within a homologous recombination subset, and not for everybody, but it was in the post-Abienza or the post-Abienza docetaxel space. And now we have two trials, really, that are in the third line or fourth line or fifth line space, depending on how you look at it. These are the CARD and the VISION trials. And the CARD trial was for cabazitaxel post-docetaxel and either Abienza, and then compared to Abienza and basically showed cabazitaxel was better. And the VISION trials with PSMA 617 lutetium, and basically showing it was better than standard of care. So this is your overview. This is your clinical decision-making, which I can turn into an hour talk, but I will not. There are a couple of things that are really critical to think about. First of all, is the drug available at a cost the patient can afford? And we do see in America that part of the disparities and part of the underutilization of some of the newer drugs are really a consequence of not affordability. And yes, there are a variety of programs, but they're not always easy to access. And sometimes the patient may not qualify for the program, and the affordability of treatment remains an issue for many patients. We talk about the drugs endlessly, but we also have to talk about the patient. The performance status, the age, the comorbidities. Alan was nicely given an example about the patient where ADT monotherapy might be used. It's a nursing home patient, perhaps. But these performance status issues are really prevalent throughout the disease that we treat. And comorbidities are very important. William was talking about cardiovascular comorbidities. This influences our thinking about how we approach the disease. And of course, the laboratory assessments, some people will have thrombocytopenia, some people have elevated in their liver function. Their patients are symptomatic or not symptomatic. So these patient-related variables are very critical and go beyond the drug itself. Prior therapies are also important in my personal decision-making. Response to resistance and duration of prior therapies. If you put somebody on a hormonal therapy and they go a long, long, long time, they tolerate it well, then a secondary hormonal therapy can make sense for that patient. On the other hand, if you put a patient, say, on ADT-ABI, the addition of a second hormone, if that patient is going to fail 6 months later, is probably not a very good idea. And then the burden of disease. We had a nice discussion on the oligometastatic disease. Thank you very much. And as it turns out, that's not only important in the castrate-sensitive space, but also the castrate-resistant space. And it turns out that it's more appreciated today that we could have either oligometastatic or oligo-progression in ways that we didn't previously appreciate, and that's important. The location of the disease matter. Is it bone? Is it liver? Is it pelvic lymph nodes only? The lymph node only patients do quite well. The liver patients do quite poorly. And it turns out the bone is somewhere in the middle. The pace of disease, we have PSA doubling time as a surrogate for that. Very, very critical and part of our decision-making. Systemic or focal progression, that gets back into oligo-progression, non-oligo-progression. We didn't mention phenotype. Neuroendocrine cancers are real. Anaplastic cancers are real, and they're contrasted to the adenos, and we have to think about those when we think about it. And then molecular biomarkers, we've talked about BRCA, and then we're going to continue to talk about BRCA and other markers, very, very important. Image-based biomarkers are now important. So PSMA has already come up. So in essence, I'm synthesizing the elements of the talks this morning in the thinking that we bring forth to metastatic CRPC. We also have to think about clinical trials, and sometimes there are great clinical trial options that are available, and sometimes they're not. And adverse event profiles are important, and patient preferences are important. I kind of like the way Alan put it is, are we the waiters at the restaurant? Do we just serve whatever the patients want us to, have ordered for us? Are we going to add a little bit of influence there? But of course, patient preferences do matter, and we have to listen and discuss in a very significant way. Now, these are the standard therapies today, and exactly as William was saying, all of these new hormonal agents, whether they're abiraterone, apalutamide, enzalutamide, darolutamide, they're all moving earlier and earlier. And that is leaving behind a very changed CRPC, a very different castrate-resistant disease as compared to what we used to have. And the NCCN guidelines have adopted the sequence matters approach, and I'm going to cover it briefly, and I think it's important. So first of all, that patient who may have had ADT in the conventional sense, an LHRH analog, or maybe an older antiandrogen such as bicalutamide, these patients are carved out in the NCCN guidelines, and the preferred regimens are going to be Abi, Enza, or docetaxel. Now, they're useful in certain circumstances like radium and CYP-T, but the bottom line is this category of disease is going to be different from the next category of disease. And here we're talking about the patient who had prior docetaxel, and this might have been a charted patient, or it may have been somebody who had gotten docetaxel initially, and now you begin to think about the hormones Abi, Enza, again, category 1, but also cabazitaxel, so a little different setting. Now, cabazitaxel carbo is going to fit in there. That's particularly for the neuroendocrine type cancers. Mitoxantrone, rarely. Radium simple cell T, a little bit rarely, but we don't have a lot of data here. But nevertheless, this contrasts with those individuals who have had the prior novel hormones. And when I say novel hormones, I'm going to mean either abiraterone, enzalutamide, apalutamide, darolutamide, one of those four, which are the current ones that we use. And now, if you're post these novel hormones, the preferred regimen today, and today emphasis is on today because we already have a positive phase 3 whose data we haven't seen yet. Today we use docetaxel, and then there are a whole variety of other choices. Some of these other choices are molecularly driven, like the olaparib or the rucaparib. The radium, of course, is for symptomatic bony metastatic disease, and then simple cell T would be that relatively asymptomatic person. Now, we're in the era today, and particularly if you're using triplet therapy up front, where the patient may emerge with castrate-resistant disease and already had docetaxel and a prior novel hormone. And here we're entering into sort of new games in town. The lutetium study, which I'll be covering it very briefly in a moment, and then more extensively after the break. But again, we begin to think about things like chemotherapies and other variety of combinations, even pembrolizumab in certain circumstances. So what I'm really trying to emphasize is that the way you get to castrate-resistant prostate cancer and the treatments you receive are no longer the simple ADT and then move on. It could be ADT docetaxel, ADT abiraterone, ADT plus abiraterone and docetaxel, and each of these circumstances set the plate for a different set of choices for the clinicians, and that's really the important thing. Now, I'm going to quickly run through what I call molecular and image-based biomarkers, because these are how we choose patients in a particular way. So we have the homologous recombination repair genes, BRCA1, BRCA2, PALB2, RAD54L, et cetera. And olaparib is approved for the indication of mutated homologous recombination repair genes, post-novel hormones or post-novel hormones, and docetaxel. Now, rucaparib is indicated in the same situation And the post-docetaxel actually, post-abiraterone, enzalutamide, are docetaxel for BRCA1, BRCA2 only. It's not all the homologous recombination repair genes. We have mismatch repair genes, and these are the MSH2, MSH6 sort of series, and we have an FDA approval in a tissue-agnostic way, actually, not specific for prostate cancer, but for any of the cancers, for PD-1 inhibition with pembrolizumab. And then PSMA PET positivity is sort of the newest kid on the block, and that is an image-based biomarker. So let's very briefly run through some of these molecular biomarkers and note that they can either be tissue-based or ctDNA-based. Circulating tumor DNA is really important, and a lot of times tissue is not available. So we need to be cognizant of the fact that circulating tumor DNA can drive decisions as well. One of the things that I like to emphasize, and this is a beautiful paper back in 2016 in Cell, looking at the heterogeneous nature of metastatic CRPC. And it turns out that almost every patient is a little bit different. Yes, there's certain defects that are grouped together. Yes, there are defects that we can take advantage of, but there's a lot of heterogeneity among these patients. DNA repair defects are present in maybe about 25%. And there are a lot of different definitions of DNA repair defects, by the way. And importantly, the PROfound study with olaparib, a PARP inhibitor, showed that there was a survival benefit in the use of olaparib as compared to standard hormonal agents for metastatic CRPC. But one of the things that was kind of interesting, we were speaking with Alan and William beforehand about not all genes are created equal. And I think William was saying that. I said, I have a slide on that. And so here's the slide on that. And you know, if you look at the bars, these are the medians, and they can be a little bit deceptive. I really prefer to look at the hazard ratios. And I'll tell you, for PARP inhibition, BRCA2 is a great target. BRCA2 really, really works. And BRCA1 works. And it also turns out that some of the rare genes are sort of interesting, but are not really definitive. But there are other genes like ATM CDK12 where there's really not much evidence. The same could be said for CHEK2. And these genes I had kind of put in a little bit of a hierarchy. This is migrating. And then Alan was kind enough to show me his real analysis that at least corroborated this. So thank you for the real analysis. I would have showed that had I seen it beforehand. I missed that one out. But BRCA1, BRCA2, and PALB2 are the ones that are really sensitive. And then there are others, ATM, CHEK2, BRIP1 is a tiny little bit of evidence, RAD51B, FANK-A, RAD54L. So these rare genes, there are a couple that might be interesting, but the bottom line is BRCA1, BRCA2, and PALB2 are the ones where you can really do well with the PARP inhibitors, and I think that's important. Now, the circulating tumor DNA, I wanted to emphasize because tissue is not always readily accessible. There's a very nice recent article from Maha Hussain looking at the tissue acquisition and the variety of ways that analysis was successful or not. I didn't include it. I just didn't really have time enough. But I did include this, and this is circulating tumor DNA. And on the left, you have the circulating tumor DNA. On the right, you have the tissue. And the bottom line is, for the BRCA1, BRCA2 ATM, which is so-called cohort A in the PROfound study, that there really was no difference. Now, importantly, there's something called CHIP. And CHIP is these abnormalities of unknown significance that can be in circulating cells. And it turns out that you can have false positives on the circulating tumor DNA, but there are ways to work around that, but they're not necessarily conventionally available. Now, moving back to this heterogeneous group of diseases we call CRPC, there's also a subset of patients with a very high mutational load and mismatch repair gene alterations. And for here, we have pembrolizumab with an FDA approval. And this is important in my mind because even though these patients are rare, when you identify them, they can have incredibly robust responses. And I have some amazing responses for Pembro in the context of very high MSIs, very high TMBs. By the way, if you look at the TMBs you're getting back on circulating tumor DNA, it's going to come out above 10, which is supposedly high, and that's not a very good marker. The type of patients I'm talking about have the TMBs, tumor mutational burdens, up in the 100, 150 range. So those are the patients that really do respond well. Now, I want to celebrate precision medicine, and I do, but it's only going to work in about 20% of patients today because I've carved it out in pretty narrow terms. We're going to give the Pembro for those that are mismatch repair deficient, high TMB, MSI high, and we're going to use BRCA1, BRCA2, PALB2, and a couple of rare genes for the PARP inhibitors. But that's only about 20% of patients. So Theranostics gives us a better chance. Now, Theranostics is sort of the idea that we might put a radionuclide on a linker and a ligand and be able to target cell surface proteins, and we might be able to see them, and that's what PSMA PET is, or we might be able to treat them, which is what PSMA 617 lutetium 177. The brand name for that is Pluvicto. I try to avoid brand names as a whole. Now, here was the definitive proof that the PSMA lutetium 617 was able to show a benefit, a prolongation of survival, improvements in radiographic progression-free survival, unequivocal, leading to FDA approval, and more. We also have supply chains. I'm not going to get into supply chains right now, but that's a big mess. Now, therapeutic combinations that deserve to be used as standard of care. This is a hot topic, particularly the PARP inhibitors. I'm not going to go down that PARP inhibitor path, which I could, but it would be long and perhaps a little complicated. But in my mind, based on the data that I've seen, we're not going to be using combination therapy as a whole, except for when a BRCA mutated patient is presenting. And I absolutely positively believe that a combination of a PARP inhibitor and a novel hormone in that context can be really, really good. If you look at the analysis of the data today in trials like PROPEL or TALPRO-2, what we see is if BRCA is combined with an androgen receptor inhibiting agent, whether it be abiraterone or enzalutamide, you can really knock it out of the park with a combination with the PARP inhibitors. But that's for another day. I have a few more, what I call additional tidbits and caveats, and these are just a couple of things along the line. One of the things that I have sort of enjoyed learning more about is using circulating tumor DNA, not just for treatment selection, but also as a biomarker for disease response and progression. And here's a patient, and we were encountering this BRAF K601E mutation, which is a really rare mutation. We weren't really sure what to do with it. And we kind of stumbled on using a taxane platinum regimen on him. And here you can see, and we were using, by the way, the chemotherapy in an intermittent manner because we'd kind of wear the patient out, would give him a break. And what we would do is we could make this mutation go away, and then we'd give him a break, and it would come back, and then we would treat him again and make it go away. And you could see this pattern that coincides exactly with our chemotherapy regimen. And you could see the response, and then you could see the progression when we took it away. So that was just a nice sort of example. We published this a couple years ago. Here's a patient who's on pembrolizumab, and they happen to have a whole variety of alterations in their circulating tumor DNA, all of which completely went away with pembrolizumab. And he actually had a very bizarre mutation in his MSH6, and we couldn't pick it up on the circulating tumor DNA, but we could follow the other mutations that were present and see them go away. Oligo-progression, okay? This gets a little interesting, and this is a case that Howard shared at a conference recently, and with permission, I'm using his slide here. And this is PSMA PET, and you're seeing a case where systemic therapy is controlling the disease. The PSA goes from high to less than 1, then begins to rise. And with a little more continued rise, what you see is a solitary PSMA PET positive lesion. And that gets radiotherapy. And for the next 2.5 years, the patient doesn't have any more progression. So you don't have to change your systemic therapies. You can radiate the oligo-progression with SBRT and then keep going. Now, one of the things that I think does not quite get enough attention, and maybe this is just me, I'm going to call it the alternative and better tolerated dosing regimens. There's a really nice study from Finland, Denmark, and a couple of other Nordic countries looking at 2-weekly versus 3-weekly docetaxel. And it turns out that as a secondary endpoint, there was an improvement in overall survival with the Q2-week regimen, and it was better tolerated. There were fewer cases of neutropenia. It was less fatigue. It was a little more edema, but overall it was a better tolerated regimen. And I often use the 50 milligrams per meter squared Q2 weeks instead of Q3 weeks based on these data. And then something that caught a lot of attention when it first came out, but not everybody is aware of it, is abiraterone is prescribed today as 1,000 milligrams a day without food. And it turns out that if you dose it with food, that you actually turn out to have the same results using 250 milligrams. So this is a great cost-saving measure. So for people having difficulty with affordability of drugs, you can take 4 pills a day and turn it into 1 pill a day. Instead of taking it on an empty stomach, you take it with a full stomach. And the outcomes appear to be relatively similar, not definitive trials, but let's put it this way. You see on the top the PSA waterfall plots, on the bottom you see the time of progression. There's nothing going on that's any worse here. And that's important work from the University of Chicago, the NCI, and others. Now, this is probably the most controversial area. We could talk about this for an hour. High doses of testosterone in selected patients. Now, there are those who are a little more liberal than I am, but I would like to say that the disease can accelerate in some cases. So I don't use this in high volume disease. I basically think about the patient who could be eligible only among those who can have progression and it won't really harm them. So maybe they got a few lymph node metastasis, maybe they got a relatively low PSA. If you have somebody with a bunch of spinal column metastases, that is not the patient you even want to think about in my mind. And is a really nice trial from Hopkins. Sam Dinmead gets a lot of credit in my mind for really bringing this to the fore. It's called the Transformer trial. And the term that the Hopkins people use is bipolar androgen therapy, or BAT. And here they were taking people who are post-abiraterone, and what you've got on the left-hand side is the PSA waterfall plot for enzalutamide and BAT in the instance where the patient was coming on to trial. And you can see that the actual PSA response rate for enzalutamide and BAT is pretty much the same, but there are more patients who have an acceleration in their PSA, in my estimation, which, by the way, the paper does not point out, but nevertheless, I think there are more patients who can accelerate, as well as the equal number of patients who respond. Now, what was really interesting is that the patients then went on to cross over. So the BAT patients then went on to enzalutamide, and the enzalutamide patients then went on to BAT. But what was really intriguing to me is the PSA response rate for the enzalutamide post-BAT was actually 78%. That's really high. So you kind of resensitize the axis, and maybe what we call castrate-resistant prostate cancer is going to become sort of a new type of disease in that post-BAT situation. We have played around with this a good bit in our clinic, and I'll simply say that some of these post-BAT responders go on and on and on. They can really have a long duration. And occasionally the BAT responders can have a long duration. I've got one guy who's been, we treated with that for like 2 years and then stopped. He's been off all therapy for the last 2 years after having BAT for 2 years. So, and he was post-docetaxel, post-abiraterone. Now, summary. Multiple agents have been shown to prolong survival. Absolutely true. Trying to get these things sequenced right is in the midst of changing because these novel hormonal agents are all going earlier and earlier and earlier. And that's really important. They should go early and earlier. That's where you get the biggest bang for the buck. Bring them early on because the patients can benefit the most. I think chemotherapy continues to play an important role, but I use what I call better tolerated regimens in the castrate-resistant setting when I think it's appropriate. Biomarker selection, here to stay. We're going to need to learn more about it. We're going to dive deeper. And by the way, looking at circulating tumor DNA is really just the first step. There's so many more ways that we can analyze what's circulating in the bloodstream. And newer radiopharmaceuticals, they're going to shape the landscape going forward. And with that, back to you, William.